The next presenter is Dr. Tatiana Cabrera. Here she is. Renal mass ablation, what is the sweet spot?
Thank you very much. Thank you very much, everybody, and thank you for both societies for having me here. I have nothing to disclose except that I am not a urologist. I'm interventional radiologist at McGill University Health Center in Montreal. Tomorrow we have a talk of more detail about ablation, but today they asked me to do this. What is the sweet spot, how we decide the lesions that we have to treat. And I'm very happy, as I mentioned before, it's about having all the options on the table for give the best treatment to the patient. And maybe I will give a third thought on this table, so not only two. Thank you very much. Do I advance? You know this very well by heart. It's just the guidelines, one of the multiple guidelines, but where we are there on the third square of between partial nephrectomy, radical nephrectomy, or thermal ablation for small renal lesions. And how are we going to decide what lesion goes to ablation, what lesion goes to surgery? That's a little bit what I would like to bring today. So we're looking for lesions less than 3 centimeters where the result is similar to partial nephrectomy. Now, the thermal ablation, it's called because we have multiple techniques that we're going to see later on, has a favorable morbidity rate. So we have lower transfusion need, lower hospital stay. And for example, in McGill, almost all our ablations are as a day surgery. So the patient comes early in the morning, we do the procedure, they stay 4 to 6 hours in recovery room, and then they go home the same day. Again, it's better to recover at home than to recover with multiple patients sharing the bathroom, as it would say. So it's a shorter procedure time. We're talking about an hour or 2 hours, depending on the location. It's a quicker recovery, and we also need a lower narcotic requirements. It's a little bit of a fear. So we know that the main limitant, maybe also as for partial nephrectomy maybe, is the tumor size. And it's well known, at least on the group of radiologists, that lesions that less than 3 centimeters, call it in the kidney, in the lung, or in the liver, we have a very close to 100% success. However, as they start to grow between 3 to 5 centimeters in the kidney, we have almost 40% failure, which is a coin in the air. So size is really our main enemy. And then you're going to say, well, but why am I'm treating a small lesion if we can observe or one thing is that we have to understand is that the smaller the lesion, the better we will be. And there is always a risk of upstaging and recurrence, even if the lesion is very small. And I know it's less than 10%, but it's always a risk that we have to discuss with the patient. So how do we choose the patients? There are many ways many scores that have been created to choose the lesions. I put a few ones. Maybe I'm going to speak about 2, the one that is interesting for you, the one that is interesting for us, interventional radiologists. So the renal nephrometry score, it's very, very easy. And it's good to have it because at the same, somehow we are talking the same language, radiologists and surgeons. And that's the idea of this renal score. It was created for partial nephrectomy. Somehow it can be extrapolated for ablation. But I will show you the other, a better one. So the renal nephrometry considers the size of the lesion, the location, if it's upper pole, well, the poles or the midlines. It considers the proximity with the collecting system, and it considers if it's endophytic, exophytic. And it's just to say complexity risks that we have. So here is a little bit to help the decisions and the prognosis of the ablation. Now, if you see this lesion, on renal nephrectomy, nephrometry is ideal. So it's less than 3 centimeters, it's almost exophytic, it's far away from the collecting system. Anterior, posterior really doesn't matter, it's just for planning. And it's on the lower pole. So with this, we're going to say that this is a low-risk lesion. But what we have to consider is that we have other structures around that when we are working on percutaneous, it's very important to consider it. So for radiology, the Ablate renal score has been created. And this is a little bit more useful for us in the sense that we can consider the size of the tumor, but we are also talking about bowel proximity. If the energy that we are applying extends to the bowel, we're going to have severe complications. The location within the kidney, endophytic, exophytic again. If we are close to the ureter, that's another very important criteria when we're having medial tumors. If it's touching the renal sinus fat and endophytic, exophytic. So very similar to the renal score, but it considers other structures that for us radiologists is very important. So here is the example of an 80-year-old man. He has a severe cardiac disease, he's anticoagulated, and the cardiologist said that we cannot stop the anticoagulation. We have that renal mass that it was proven papillary renal cell carcinoma, and although he's 80, he wanted to be treated. So look how close it is from the bowel loop. Now, it's not to contraindicate a procedure, it's just for us to know how we're going to prevent any damage. And here, the decision was to perform an ablation. You see the hydrodissection that we're doing all around the lesion. We inject high volumes of saline to give a good separation, and sometimes we can inject some CO2, depending on where we are. So we play with gravity, fluid, or air to push away the structures. That's our robotic way. And then we can position the multiple needles, depending on what system are we using, the number of needles. So we know that microwave ablation can be only one needle, but cryoablation or IRE will need multiple needles to be positioned around, and each needle has a different axis, so we have to consider all that. This patient went very well. You see the follow-up with a good necrotic area, with a ring of ablation, very classic for cryoablation. And you see the colon is against the area that we ablated, but without any complication. What is the sweet spot? Of course, it's a small lesion, posterior, far away from any structure like this one, and just showing you the ablation with 3 cryoablation needles, the procedure, and the final result. We take a little bit more tissue. This criteria is also going to help us to decide how are we going to do the procedure. If we're going to use ultrasound, if we're going to use CT scan, or if we're going to use MRI. The main decision is by the imaging that we have and how comfortable we feel with each technique, but we are also limited by our reality. So for example, you may think that MRI could be ideal, but the problem is that the time and the cost of MRIs are so high that it's not available as much as we wish. Our procedure is, I would say 99% under conscious sedation. It's very rare that we need a general anesthesia for an ablation. And tomorrow we're going to speak about the ablation energy, if we use radiofrequency, microwave, cryo, IRE, SBRT. It's patients on day surgery. And one thing that we do also to avoid more the pain and reduce also the use of sedation, because the patients most of the times are in prone position, so give a sedation that also gives a risk, is that we use the quadratum lumbarum block, and we're having very good results. It's still not on published, but we are having a good control of pain during our ablation. Now, the renal score and the Ablate score always give us the ideal lesion, but that's not the truth. That's not the reality of our daily life. This is a patient that is more or less what we have on the most of the ablations. I'm giving you the original image of a CT scan, so this is a perfect axial image, and you can see that the vertebrae are on sagittal, so you can imagine how tortuous what the rotoscoliosis that this patient has. She already had right nephrectomy for an RCC, so single kidney with multiple pyelic cysts, and you see the colon just there, and the 2.7 centimeter tumor. So not an ideal candidate for surgery, not an ideal candidate for ablation, but these are the patients that we have to discuss all together on a multidisciplinary decision. And when we say multidisciplinary, we also love to consider that it's not only urology and interventional radiology, also the opinion of the patient is very, very important, and it's very important that we tell the patients what are the benefits and risks for each procedure, so they can also have their own decision of the treatment that they want. I love these guidelines because they say that for ablation there is no absolute contraindications, and yes, we try to accommodate as much as we can and to say always that we can do it if the patient requires that. They are just saying fever, severe coagulopathy that can be corrected, and those are the only relative contraindications that they say. So here is the case. Pushing away with fluid and with air, because gas is a very good thermal isolator. So if we can put fluid, push away the structures, but if we can also put air to isolate the temperature of the system, is very good, and that's what we did for cryoablation needles for this lesion. And it went very well. It was well tolerated by the patient. The only problem is that she developed, as you can see there on the upper pole, a leak, a urine leak, that it was treated with a double J. On the image on the right, you can see the loop of the double J that was placed by urology, and the patient is doing very well. So that's how we can bend our techniques all the time. More than the renal and the Ablate criteria, number one also discuss how are the general conditions of the patients. If the patient is a candidate to surgery, I'm really just amazed of what I'm seeing this morning of the things, the surgeries that you are doing. So if the patient is surgical, yes, why not to consider that treatment? But if he's not, then life expectancy, comorbidities, cardiopulmonary function, chronic diseases that we see very common, solitary kidneys. If we have a risk of new tumors like von Hippel-Lindau, like hereditary RCC, multiple bilateral tumors, etc. So those have to be considered. And many times we're trying to design a flow for renal tumors like we have for liver. And the most important thing is the discussion on a multidisciplinary round. So this, if you ask me what is the sweet spot, this is the sweet spot. It's small, it's almost exophytic, is posterior. This patient had, in 1996, a right nephrectomy for RCC. In 2014, a right lobectomy for RCC metastasis. In 2018, 2 pancreatic nodules that were treated with SBRT, and they were also RCCs. And in 2020, on the single kidney, he developed a new lesion, and the decision was to do cryoablation. Unfortunately, I don't know, this time was decided just to place 1 needle, big mistake, because there is a recurrence a year later. So the decision was to repeat the ablation. There is a leak again during the procedure, but this was healed on its own, and the patient is doing well. So when we see the history of this patient, we have more than 25 years with a renal cancer, and that's also something to consider. It's not one lesion, one treatment, and we're done. It's a whole history. Cancer today is a chronic disease that we're going to see new tumors on the same patient, and for each tumor we will have to decide what is going to be the best treatment. Sometimes it's surgery, sometimes it's ablation, sometimes it's radiotherapy. And thank you very much for having me on this conference, because together we can decide which is going to be the best lesion to ablate, and what complications we may find on each treatment, and how can we reduce these complications. So thank you very much.